Hello, everyone. We all love stories, don't we? And today we will witness the systemic stories our eyes reveal. Welcome to another chapter of Chronicles with Experts at Ocular Surface Guru. For practical and case-based discussions, we will open up systemic stories which connect ophthalmology with rheumatology. And to do this, it is my utmost pleasure to welcome Dr. M. Kavitha, a senior consultant rheumatologist from Kavitha Hospital, Chennai. We have been working very closely with her for the past few years, and she'll be guiding us through the discussions today, along with my colleagues, Dr. Varsha and Dr. Mukundan, who will be bringing in questions that we face in our day-to-day practice. Welcome again, Dr. Kavitha, and over to you, Varsha.
Welcome, Dr. Kavitha. A pleasure to have you with us today. To give a brief guideline, this is going to be a case-based discussion where we have curated 4 clinical case scenarios that we commonly encounter in our day-to-day practice, focusing on 3 key aspects. How do we diagnose these patients? How do we approach the treatment? And how do we monitor the patient? So without further ado, let's get started with case scenario 1. Case of a 65-year-old lady who presented to us with the complaints of chronic dryness and the burning sensations in the past 2 years. She also complained of some dryness in her mouth. She did not have any joint pain, and on examination, the Schirmer's was 2 and 3. There was diffuse staining of the cornea as well as of the conjunctiva. So she was diagnosed with severe aqueous tear deficient dry eye. So in such a scenario, when we as an ophthalmologist suspect to have any kind of an underlying systemic Sjögren syndrome, how do you clinically approach for diagnosing such patients? Second, blood investigations that these patients should be subjected to, and can, as an ophthalmologist, we subject these investigations to the patients, or we should just refer them to a rheumatologist?
This is a typical case scenario, like a 65-year-old female, the most common age group of a Sjögren syndrome. When that case is referred to me from an ophthalmologist, apart from the dry eyes and dry mouth, we also look into certain set of questions like early morning stiffness, joint pains, any admissions previously for muscle weakness, because primary Sjögren sometimes can present with hypokalemic paralysis, any skin lashes like purpuras, and any other systemic features like interstitial lung disease or not. Apart from that, whenever you have a dry eyes in a patient, always look into the mouth of the patient. You can see sometimes central dental caries even without a Zika symptom. It tells you that this patient has got reduced secretions of the saliva also. That is also a clinical clue towards a primary Sjögren syndrome. See, not all patients with Zika symptoms do have systemic symptoms. Certain people of them will have a glandular symptom alone. Certain group will have extraglandular symptoms alone, and many patients both glandular and extraglandular. So this patient can be just a glandular manifestation of Sjögren syndrome, or it can be a overlap also with extraglandular manifestation. The second part of the question is, can ophthalmologist order for investigations? Definitely yes. When you suspect a Sjögren syndrome in this patient, it could either be a primary Sjögren's or a secondary Sjögren's. Primary Sjögren's is usually dominantly a glandular disease, along with you can have anti-SSA and SSB positivity. So investigations which we send is complete blood count, ESR, CRP, rheumatoid factor, anti-CCP and ANA to evaluate for a primary Sjögren syndrome. But if this patient tends to have a secondary Sjögren, secondary to rheumatoid arthritis, scleroderma or lupus, scleroderma and lupus clinical features you can pick up something. For rheumatoid arthritis, certain patients will have only dry eyes, dry mouth and not have even arthritis symptoms. Those patients can be picked up with rheumatoid factor and anti-CCP. This ESR and CRP tells you whether the acute phase reactants are elevated and patient has an inflammatory component to them. And ANA by IF is a screening procedure which will not have anti-SSA and SS. But if it is positive, go ahead doing an ANA profile by immunoblot, which will have this anti-SSA and SSB positivity also. If you have a very high suspicion of a primary Sjögren's, like the patient has an acute phase reactant increase and the patient has a salivary gland swelling, the parotid glands are enlarged, the submandibular is enlarged, and then they have a central dental caries, along with the dry eyes are there, definitely go ahead and do anti-SSA SSB separately, even if the ANA IF is negative.
Thank you, Dr. Kavitha. Regarding the blood test that you suggested, what are we looking when we are ordering a CBC, ESR? And in some patients, that if the patient doesn't have salivary gland or submandibular gland enlarged, do we still go ahead if the ANA comes negative with SSA and SSB antibodies? And if the patient is not having any systemic symptoms, CCP, and all this blood reports comes negative, if the dry eyes is severe, still go ahead ahead and subject this patient to a rheumatologist?
Coming to the first part of it, the complete blood count always gives you a basic knowledge whether this patient tends to have a leukopenia. Many times with Sjogren's or lupus, the patient tends to have a leukopenia. Sometimes there can be a thrombocytopenia also. And the acute phase reactants, particularly the ESR, I would tell you, as a marker of any autoimmune connective tissue disease, as a good positive predictive value. Though it is not very specific, but the sensitivity with autoimmune rheumatic disease is slightly higher up with ESR and CR. What is a normal ESR? Age plus 10 divided by 2 for female and age divided by 2 for a male. So if there is a patient who have a 65-year-old female who can have a ESR till 30-35, that is considered to be normal. Patient tends to have a very high ESR of more than 50. Definitely there are underlying autoimmune disease has to be suspected in such patients. The second part of the question. Even if ANA is negative, see, if this patient is almost 20 years, maybe the suspicion for me will be slightly on a lower side if everything is negative. So ANA is negative, I leave them. But at 65, which is the most common age group to have a primary Sjogren's, then I might proceed on with an ANA profile just to see whether SSA, SSB is positive or not. Because 30% of patients can have an ANA negativity, but anti-SSA can be positive. So in patients with high risk or higher suspicion, I would definitely proceed on with doing an ANA profile. The third part is, should we refer to a rheumatologist? If all are negative, the chances are slightly on a lower side. But again, as rheumatologists, we tend to pick up certain clinical clues which might be in favorable of a autoimmune CTD. But everything is negative, I would still leave it to an ophthalmologist.
Can you highlight on the role of USG of glands or the lip biopsy? Like previous case was a 65-year-old lady, but recently we had a case of a 20-year-old female optometrist who complained of dryness. Her Schirmers were 7 and 8, non-invasive breakup 8 seconds. She had come with all the reports to us. Her initial blood workup was completely negative, but when she underwent a minor salivary gland biopsy, it came back as positive. This is an age group where people want to undergo refractive surgeries and they are referred to us with a mild aqueous deficient dry eye. So how do we proceed in such patients when the blood workup is negative? Where do you place lip biopsy in such patients?
This segment of seronegative Sjogren's is coming up. Maybe in next 2-3 years, we are going to have multiple autoantibodies apart from your SSA and SSB into the field. But coming to the lip biopsy, which is a minor salivary gland biopsy, is definitive, particularly the focus score of more than 1. We do it in patients who are negative for everything. When the suspicion is higher, has to be done at a good center and a pathologist should be adept in reading it. And they have to give the exact focus score, because more the focus score, like more than 3 or more than 4, we also follow up for a lymphoma in the future for such patients. A focus score of 1 or 2, there is a lymphocytic infiltration of a salivary gland, which is confirmative of a Sjogren's syndrome. And the second thing is ultrasound salivary glands. It is observer dependent. Not many of them are as good in performing as ultrasound of salivary gland. So I do not personally order, though it is actually in the recommendations per se. But I do write option for a lip biopsy in most of the cases when the suspicion is higher, or even sometimes I have a suspicion of sarcoidosis or an IgG4 related disease. Lip biopsy will pick up every single thing of this, all the 3.
That's very informative, Dr. Kavitha. So, if the patient is now diagnosed to have a primary Sjogren's syndrome, do all patients actually need an immunosuppression, or do you have any specific guidelines or indications about starting these patients on immunosuppression?
Primary Sjogren's, if it is glandular, the recommendations does not actually favor a disease-modifying anti-rheumatic drug. In fact, rheumatologist's role in such cases is very, very limited. I actually do feel that we do not help the ophthalmologist colleagues a lot when it comes to treating the dry eyes in the primary Sjogren's syndrome. When the patient has an associated arthritis or an interstitial lung disease, we have very clear-cut guidelines of going about what disease-modifying drugs, methotrexate, mycophenolate, mofetil. Sometimes we go to the extent of giving rituximab in patients with severe peripheral neuropathy. So the systemic or the extraglandular manifestations determine the role of immunosuppression. There are few trials which says rituximab improves the dryness of eyes, but no recommendations suggest to straight away start with systemic immunosuppressive therapy for exclusive glandular symptoms. Most of us had hydroxychloroquine for such patients, considering hydroxychloroquine is an anti-interferon and primary Sjogren's is driven by interferons, but exclusive for the dry eyes Systemic immunosuppression role is very limited.
So it's most commonly that hydroxychloroquine that you start, or there are other immunosuppressants also that you would consider it if the patient needs an immunosuppressive therapy.
Dry eyes only hydroxychloroquine, Varsha, but we do give methotrexate for patients who have arthritis and arthralgias. The mycophenolate mofetil, if the patient tends to have a glomerulonephritis or an interstitial lung disease associated with the Sjögren syndrome, or even foot drop, peripheral neuropathy, peripheral neuritis, those patients demand an immunosuppressive therapy. Hydroxychloroquine is limited only when there is mild fatigability, arthralgias, dry eyes, dry mouth, and all those things. But other patients, clinical features of Sjögren syndrome determine the immunosuppression. Sometimes we go to the extent of giving even rituximab for patients who have a severe progressive interstitial lung disease or a severe progressive glomerulonephritis, even after steroids and mycophenolate mofetil.
So definitely a referral to a rheumatologist, I would think that it is needed. But in a patient who has just limited ocular and oral scar, what as an ophthalmologist should be the interval of time that I should be referring a patient to a rheumatologist? And do you see systemic evaluation of symptoms over a period of time in such patients?
The follow-up with the rheumatologist is very important because there can be additive systemic symptoms. They can develop an interstitial lung disease or a peripheral neuropathy. That is one thing. But the second thing, such patients have a tendency to go with lymphoma on a longer run when there is an exclusive glandular symptoms. ESR is very high. There is hypergammaglobulinemia and low complements. These three group of patients, even with only limited Zika symptoms, have to be followed up on a regular intervals, at least 6 months once, just to identify whether they develop symptoms of lymphoma. Because all of the autoimmune connective tissue disease we have, the highest chances of having malignancy in the future is with the primary Sjögrens. They are proliferating lymphoid follicles. Anytime they can be metaplastic and they might move in for NHL or HL.
So once the patient is diagnosed with primary Sjögren's and you have started the patient on immunosuppressive therapy, how is it that you follow up these patients?
In a case of Sjögren's, methotrexate, mycophenolate mofetil, rarely azathioprine, but methotrexate before starting, I would definitely do a complete blood count and a liver function test. So we look into the CBC. The hemoglobin is less than 10 grams. We tend to wait many times, correct the hemoglobin, then start methotrexate. We monitor their liver function test and a complete blood count whenever the patient is on methotrexate. Initially, after 2 weeks and then after 4 weeks, we start at the lowest dosage possible, like 10 milligrams per week, and then escalate it to 15 milligrams based on the CBC and SGOT SGPT. Usual recommendations are 0, 1 month, and 2 months. First 3 is every month. Sometimes stringent guidelines say once in 15 days. After it goes to the maximum level, maybe 15 milligrams or 20 milligrams of methotrexate, and patient does well with that, then once in 3 months is enough. 0, 1 and 2, after that every 3 months. Coming to mycophenolate mofetil, one of the safest immunosuppressions which we use. The usual dosage of mycophenolate mofetil is 30 to 50 milligram per kg body weight, and the maximum tolerated dosage should be given. Before starting, we do a CBC, creatinine and liver function test with mycophenolate mofetil, starting it at around maybe 1 gram, then slowly increase it to 1.5 to 2 grams per day. And every time we increase, tend to see a complete blood count, SGOT, SGPT, as well as the serum creatinine. Most of the times we will not have an issue with this. Sometimes there can be bone marrow suppression, but GI intolerance is one of the most common side effects. Many of our patients do not tolerate the maximum dosage which is needed to control the disease, which pushes us to stop it. We have something called as mycophenolate mofetil S. Patients who tend to have gastric symptoms can use this S. So 360 mg of S will be equivalent to 500 mg of pure mycophenolate mofetil.
So I may summarize, patients with clinical aqueous deficient dry eye, the initial assessment should begin with a focused history ocular surface assessment followed by the first line of blood investigations, which an ophthalmologist can also initiate, but a referral to a rheumatologist, particularly in older age groups, is warranted. Second thing is that if the patient is seronegative, we can consider lip biopsy. All patients do not require immunosuppression, but require timely follow-up to the rheumatologist for any kind of malignancy that might happen in the future.
So that was a very detailed discussion on primary Sjögren syndrome. Now we'll move on to the second case on secondary Sjögren syndrome. Here we have a 56-year-old female who's a known case of rheumatoid arthritis on methotrexate 15 mg. She presented to us with severe dry eye. She underwent punctal cautery, and post punctal cautery, her surface was significantly improved. As ophthalmologists, one of the key concerns is whether the systemic disease is under control or not. So how can we assess this? Are there any clinical or lab indicators which helps us to understand whether the systemic disease is under control?
See, whenever there is a secondary Sjögren's, control of the primary disease is utmost important. When it comes to rheumatoid arthritis, we normally start with methotrexate and we look into acute phase reactants, the ESR CRP. We also look into the tender joint count, the swollen joint count, amount, like the symptomatic improvement. We also have a scoring system called as DAS 28 scoring system, which has a tender joint, swollen joint, physician global assessment, patient global assessment, and CRP. So with this, we tend to pick up that the disease is under remission. Sometimes it is in the low disease activity, sometimes it is in the medium disease activity and high disease activity. This is one side of systemic control of rheumatoid arthritis. But we also depend on our ophthalmology colleagues when they say the disease is under control or not, the ophthalmological side of disease is controlled or not. Sometimes we need to escalate based on their views.
In clinical practice, we often encounter patients on other alternative medications like homeopathy or Siddha treatment. So in such cases, when they are asymptomatic, they don't have active joint pain or they have a normal inflammatory marker. So how do we safely proceed with intraocular surgery in these patients, and do the standard parameter assessment holds the same in this context also?
Holds the same, but if the ophthalmological disease activity is still high, which means that the patient's disease is not under control, even though the ESR can be normal, CRP can be normal, I would definitely convince them in moving into our drugs of immunosuppression to control the disease. If ophthalmologically very quiescent, I don't ask them to change. When we are referred, we tend to say pros and cons of disease modifying anti-rheumatic drugs and leave it to the patient's choice. We are not going to push anybody there.
Now, from a treatment perspective, how does primary Sjögren's differ from secondary Sjögren's? And in case of secondary Sjögren, associated with other diseases like rheumatoid arthritis, systemic sclerosis, etc., are there any drug of choice?
I think we have talked about primary Sjögren's, where the glandular symptoms are the dominant symptoms with extraglandular manifestations, and anti-SSA SSB is usually positive, the Rho52. But secondary Sjögren's, it takes the antibodies of the primary disease. See, rheumatoid arthritis long-standing will cause glandular destruction. This is called a secondary Sjögren's. Such patients may not have anti-SSA SSB positivity, but they tend to have a rheumatoid factor and an anti-CCP positive. Long-standing lupus tend to have a dry eyes and dry mouth, which is called a secondary Sjögren's. The antibody there could be Smith antibody, SMRNP, or the dsDNA part of it. In long-standing scleroderma causing dry eye, tend to have SCL70 positive or centromere positivity. And the treatment for the secondary Sjögren's part of it is determined not by the disease, but the manifestations which the patients tend to have. If the patient has rheumatoid arthritis, the first choice is going to be either methotrexate, leflunomide, or sulfasalazine. Scleroderma, again presenting only with arthritis, then again methotrexate is going to be the treatment of choice. The scleroderma presenting with interstitial lung disease, then mycophenolate mofetil, tocilizumab becomes the treatment of choice. For a lupus patient, straight away we are not going to start them on high dose steroids and high dose cyclophosphamide. This patient could have just a mild lupus where very low dose steroid within hydroxychloroquine and plus or minus methotrexate is just enough for the control of the disease.
And what forms the basis for you to modify or switch the treatment?
See, one thing is the tolerance, the second is the activity control. 6 weeks to 12 weeks, usually the 3 months is the cutoff period, where we go to the maximum tolerated dosage of immunosuppression. The disease is not under control, the inflammatory markers are not under control, I am not able to taper down my steroids, patient's disease activity progresses, addition of new symptoms happens at the end of 3 months or 4 months. These are the indications where I either add or switch over the immunosuppression, or the patient is intolerant, we change.
And this switchover will be always under steroid cover. And whenever we start a new medications, how long we should wait for the new drug to take action?
In cases of ophthalmological conditions where the eye is very active and I need a change of immunosuppression, I would always do it under the steroid cover. So most of our patients would achieve the maximum trough level to control the disease is usually 4 to 6 weeks. So normally if methotrexate is there and I want to shift it to mycophenolate mofetil for the eyes part of it, in this 4 to 6 weeks, steroid is used as a bridging therapy where I don't want the eyes to flare up badly. I use steroid as a bridge, so the steroids takes care, and then I am happily shifting it from one to another immunosuppression. This is the usual protocol.
The monitoring of side effects is similar to what we discussed in the primary Sjögren's, or anything different we do?
Usually the same. But one more thing I would tell you is, I would say one of the most dreaded immunosuppressions which we all have been using till we have a problem, it is a very safe drug, which is like azathioprine. We select because it is one of the most economical immunosuppressions. Whenever the patients have a thiopurine methyltransferase deficiency, the TPMT deficiency or NUDT deficiency, this azathioprine, even at a low dosage of 50 milligrams, tend to cause life-threatening bone marrow suppression. So either we do this TPMT gene testing and then start, or when I am not done at thiopurine methyltransferase level, start azathioprine at a very low dosage of 25 milligrams. Do a CBC, SGOT, SGPT. Then I increase it to 50 milligrams. Then again at the end of 1 week, we do a CBC, SGOT, SGPT. then increase it to 75 mg, then do a CBC, SGOT, SGPT, and then go up to 100 milligrams CBC and SGOT, SGPT. For azathioprine, the maximum dosage is 1-2 milligram per kg body weight. Sometimes we can go up to 3 milligram per kg body weight. For a mycophenolate mofetil, it is 30 to 50 milligrams per kg body weight. And cyclophosphamide, it is usually a monthly once pulse therapy, 15 to 20 milligram per kg body weight. And we also add mesna to that because patients can have hemorrhagic cystitis. It is reserved for life-threatening or organ-threatening inflammation in spite of steroids. So particularly when there is a very significant ophthalmological emergency, cyclophosphamide is a drug of choice. And then one more drug is rituximab, wonderful drug. We do a complete blood count with the immunoglobulin levels, serology, the viral markers, hepatitis B, C and HIV. These are the usual protocols which we follow.
To summarize, always control the primary disease in case of the secondary Sjögren syndrome, and the rheumatologist and ophthalmologist should always work hand in hand. Regarding the choice of immunosuppression, the disease manifestation is very important to pick up the right immunosuppressant than the disease itself.
We had one recent case when we had a rheumatoid arthritis patient, very strong anti-CCP positive. Arthritis was under control only with methotrexate, but she had a recurrent episcleritis not getting controlled with addition of immunosuppression also. Then we had to give rituximab just to control the episcleritis. After giving rituximab, she is absolutely symptom free when it comes to the eyes part of it. So sometimes we will escalate the immunosuppression only for ophthalmological issue and not even for the arthritis part of it.
With that, we come to the end of part 1 of our conversation with Dr. Kavitha, where we learned regarding how to approach these patients with aqueous deficient dry eye, and we explored regarding diagnosis and management of primary and secondary Sjögren syndrome. I definitely learned a lot, and I hope you did too. Don't miss part 2 of this conversation, where Dr. Kavitha sheds light on the rheumatological aspects and management of PUK, offers more insight into the use of immunosuppressive agents, and discusses some challenging overlap cases. Thank you for joining us, and we will see you in part 2. Until then, stay curious, keep learning, and keep collaborating.